Several years ago, I was living in Gallup, New Mexico on the Navajo reservation. I had a problem. My wife's 8 months pregnant, and it turns out that we don't have 24/7 anesthesia coverage in the hospital where I worked. It's challenging to find anesthesiologists to practice in that setting, so here's the bottom line. When she was going to go into labor, she was not interested in natural childbirth. And the only thing we had to offer if you came in the middle of the night was you could put in an IV and give somebody morphine. That's not great for the mom. You're kind of not really present for the birth. And it's not great for the baby either. So the idea was, what were we going to do if she wanted an epidural? Would I drive her all the way to Albuquerque, a 2.5-hour drive the day she went into labor? Didn't really know. Anyways, shown here is, this is Spider Rock in Canyon de Chelly. We would go hiking in this area for a while. I remember one night, and the Spider Rock thing will come in, I'll explain why that's important in a second. We were sort of not exactly sure what we were going to do. I was called to the ER. I'm a pediatrician, that's why we were there, and was there because we evaluated every child who came in before they had to go to surgery. And this child came in, he had right lower quadrant, severe pain. He kind of was really localizing to that area. It had come on all of a sudden. He was otherwise completely healthy, and the surgeons wanted to take him to the operating room. And so they were all set to go, and they said, no, we have this rule before you go that the pediatrician has to evaluate. So I go down there, I see the child, and he doesn't have a fever. His white blood cell count isn't that high. And for those of you who are clinicians, that sort of makes you question, does this child really have appendicitis? And it turns out that I started to ask a bunch of questions, and the dad who was there said, well, there is this funny thing. I found this in his bed. And he gave me a little vial, and in it was a spider. And it wasn't any spider, it was a black widow. It turned out he'd actually been bitten by a black widow, and a black widow spider bite under certain conditions can mimic the symptoms of appendicitis. He was admitted to the floor. He actually just got some IV pain controls better. And his dad said, you know what, thank you so much. And we got to talking. He said, you know what, I'm actually a nurse anesthetist. And if there's ever anything I can do for you, give me a call. And I said, in fact, there is. So that was how our problem was solved. When my wife went into labor, I called him up at 4 in the morning. His wife answered the phone. She said, we've been waiting for this call, came in, took care of everything. So Spider Rock. Well, I tell this story because, as you can see, I remember seeing this movie in the late 1990s. Some of you may have seen it, Gwyneth Paltrow, Sliding Doors. And the premise of the movie is that she's running to catch this subway train. She drops an earring in the elevator, she goes, she makes a subway train, and then this whole thing sort of unfolds. She finds out her partner's being unfaithful. And then the story actually splits. And there's a situation where she misses the subway, and her life is very, very different. For those of you who are more contemporary, I'm a big fan of Marvel stuff. If you saw Endgame, there's this whole premise of that is that there's a million ways something could happen, but there's only one that leads to the universe being saved. In a sense, I thought that that's sort of what it was like with this spider thing. It was so random that this all came together so that my family could get the right health care they needed. Sort of sent me on a little bit of a quest. I'm a pediatric cardiologist, so I take care of a lot of babies now who have major congenital heart disease. And this is an ultrasound from a baby who's come in. And for those of you who know this kind of stuff, this is a condition called hydrops. This is where something is wrong, and so the baby is swelling up, and this baby was only 13 weeks gestation. Had come in just to see an obstetrician for a check, and then they noticed that the heart rate was 350 beats per minute. Those of you who are familiar with that, that's something that a fetus can't really handle, and so hydrops was developing. This is a condition called supraventricular tachycardia. SVT. You think about it, this is almost, in a 13-week fetus with hydrops, this is a really bad situation. Started talking to the mom, she was 19, and I sort of explained the situation. We had the perinatologist, a number of people talked, and we sort of said, this is really serious, you could be admitted, but we're not so sure. And she said, well, on TV, don't you guys shock people when they're in rapid heart rate? Couldn't you shock me? So I was to say, is that something any of you would actually do? Think about that. It's a tough decision, not been done. Is amniotic fluid really electrolyte? By the way, this has never been done before. So you say, we could put pads on her, admit her to the ICU, we could try it, I guess. She was really committed. And then what happened is, that same week, I was at the nurse's station. The New England Journal of Medicine actually had published this paper. So as you probably see this, outpatient treatment of recent onset AFib with the pill in a pocket approach. What these researchers found is that a single oral dose of oral flecainide would actually convert atrial fibrillation to sinus rhythm under certain conditions. Again, think about that, so random. This paper happened to be there, we happened to see it in this weird situation. We admitted her and gave the woman a single oral dose of flecainide. The baby converted to sinus rhythm within 6 hours, normal birth, and the child is now a teenager who's normal. Again, so random, that sliding door or end game moment. Is this how we should practice? There's an enormous amount of knowledge in the world. How do we get at the right place at the right time to help people? That's the problem I've been interested in now for some time. These days, I am the Chief Medical Officer for UnitedHealthcare's Medicare business, so responsible ultimately for care and coverage decisions and a number of things affecting millions of people. And then we also have sort of look across all lines of business, Medicare and Medicaid, and we're the largest insurer in the country. Think about using that level of sort of reach. How can we take these kinds of lessons and scale them more broadly? Here's a story I'll tell. We wrote up that fetal cardioversion. This is Atul Gawande, researcher and well-known surgeon in the Boston area, who almost 9 years ago gave a lecture where he told this story. I'm just going to say, in brief, he had seen a patient in the intensive care unit who was in his early 30s named Dwayne Smith. 34-year-old assistant grocery manager who had been in a terrible traffic accident, was admitted to the ICU for months, actually survived and went home and was great. 2 years later, he was on the beach. He didn't feel so well. Turned out that even though everybody in the ICU had done all the stuff exactly right, they forgot to do this one thing. He had had a splenectomy. And the spleen, as you know, is a critical organ in order to make sure that your immune system works. After splenectomy, people are supposed to be vaccinated against a number of infections. He was not vaccinated. 2 years later on the beach, and he later wryly said this was the worst vacation of his life. He came down with sepsis, was admitted to the ICU, and ultimately underwent amputation of all of his fingers. Atul Gawande told this story at a commencement 9 years ago. He actually tells it every couple of years at a number of events. I heard it for the first time last year at a meeting at Ariadne Labs where he goes, and I went up to him afterwards and said, what have you guys done about this? He says, I told the story. I said, you know what? This is where the power of big data comes in. And we often talk about big data and AI and all this stuff. The hardest thing to do, and the quantity that is in the shortest supply, are people that just A, ask the simple right questions at the right time, and B, put in the work to actually answer those questions. So this is what our team did. We said, you know what, why don't we look at all the splenectomies in our entire claims data set. We have 150 million lives. Look, 14,000 people roughly had splenectomy, and then we looked, how many of them have been vaccinated? Look at that. Pneumococcal vaccine, 2% completed. Hib, 10%, and so forth. It turned out that not only that, we actually looked to see how many of them went on to develop sepsis and found a significantly higher rate of sepsis among people who were not vaccinated. First time that had been shown in large data, and we found that you only need to vaccinate 26 people that had splenectomy to prevent an admission for sepsis. Think about that number needed to treat for vaccination compared to all the other vaccinations you know about. And so we, last year, started a program of reaching out to everybody who we knew that had a splenectomy but hadn't actually been vaccinated. We believe that this will save dozens of people from an inpatient admission for sepsis. That's the end game moment, that sliding doors moment. And this is small scale. Let's talk bigger scale. What is the leading cause of death of young people that is preventable in the United States today? Opioid use disorder and overdose. Can we tackle that in the same way? This is a map of the United States, and what's shown there at the county level, from red to blue, red is bad, blue is good, of the rate of an initial opioid prescription being written in compliance with CDC guidelines. In other words, if you write an opioid prescription, if it's the first time somebody's not been on it, you shouldn't write a super long dose or duration. You should write a reasonable dose, make sure the person's not on a benzodiazepine and so forth. Look at that. That, by the way, goes from 0 to 1 in that bell curve. That is a perfect bell curve distribution. So in the United States, and this is an Optum Rx and UnitedHealthcare, this is tens of millions of people in 2017, only 50% have their initial opioid prescription being written in compliance with guidelines. This is the gateway moment because we know that the higher the dose and duration, the more likely it is that one is going to be a chronic opioid user, dependent on them, and also increases the risk of dependence. We made a nationwide decision just over 2 years ago to institute what are called hard edits at the point of sale. It is very hard. You just talked about behavior, changing behavior. We could go out to every hospital, talk to every clinician and say, hey, can you guys please prescribe better? Or we could say this is a national emergency. We're going to fix it right now. We took that latter course. We enforced compliance with guidelines at the point of sale. We turned it on in July 2017. Within 1 month, we saw 90% compliance across the country. And most importantly, what we've done here is it rolled out in essentially, because of the way contracts are written, it doesn't happen simultaneously anywhere, so there was a natural experiment. We found, if you look at the top level there, those are our markets where the edits didn't take place right away. The bottom markets where they did. 50% reduction in new chronic opioid users if you were subject to the edits. One of the things I like to think is in today's day and age when we all kind of want to have lots of attention and sort of make these dramatic cures, this is achievement. And achievement is often anonymous. There were dozens of people working behind the scenes that are responsible for stopping potentially hundreds of thousands of people from becoming chronic opioid users. And when they stopped becoming chronic opioid users, they never had that moment of putting that fentanyl needle into their arm and overdosing. That's the end game moment. I'm going to go through a couple other examples of how this can be done at scale and why I work at a payer now and believe that is one of the best places that one can institute public health at scale. This is, again, with the theme of opioid use. If you already have opioid use disorder, the first place where you get care is where you stay. Purple is behavioral health only. That yellow is detox, green is medication-assisted treatment. The only evidence-based treatment is medication-assisted treatment, and we know that if you get that in the first place, that's where you'll stay, and your risk of overdose is dramatically less. Going to detox behavioral health, the outcome is identical to doing nothing. So our policies now strongly push people into centers where medication-assisted treatment is an option. We also look at what is the first kind of doctor you see when you have new onset back pain. Turns out if you see a physical therapist, chiropractor, acupuncture, your risk of being a chronic opioid user is potentially 20% of if you don't. What does that mean? We waived all co-payments so that you could see those as the first entry provider. Let's move on from opioid use disorder. Dementia. How can we prevent that? It is incredibly difficult to come up with drugs that treat Alzheimer's disease. For those of you who work in pharma, that is known as the graveyard of pharmaceutical innovation. What about something a lot simpler? This is work we did in collaboration with Johns Hopkins. Turns out hearing loss, if it is untreated, has a significantly higher rate of progressing to dementia and 50% more hospital stays. There is not only a clinical case, but also a strong business case because looking at actual paid claims, those individuals with untreated hearing loss have $22,000 of increased medical spend over a 10-year period, more than outweighing what a hearing aid could cost. Screening people for hearing loss may be one of the best ways to prevent dementia today. This is maternal health. We talked a little bit this morning about how do we save mothers' lives. It is one of the most common problems we see is that preeclampsia, high blood pressure is what claims these women during hospitalizations. When we merge the claims with the clinical, we find that 50% of eclampsia actually occurs after birth. Again, demonstrating now this is the problem we have to go solve. When we think about home monitoring, we talked about a 3-week postpartum visit. Is that the best strategy if eclampsia is going to occur within the first week? Data can now drive those kinds of decisions. Again, avoiding that person from getting that life-threatening moment. This is teen pregnancy. Again, insurance benefit design, waiving co-payments entirely for the most highly effective forms of contraception, LARCs or IUDs. It turns out if you have a teenage girl, I have 2 teenagers by the way, and they start oral contraception. They come to you, think you're doing all the right things, you have a great sort of relationship, the risk of that individual getting pregnant within 1 year is still 10%. Why? Because it's very hard to take these. We see that over and over again. With the LARC, the risk is less than 1 in 1,000. We waived copays completely. The use of LARCs went up 6-fold. The teen pregnancy and also teen abortion rates fell dramatically nationwide. Again, having that experience, think about you just take that away. It's that sliding door moment. And insurance benefit design is what's responsible. And finally, I'll close with diabetes. Type 2 diabetes, I spoke about this 2 years ago. I was involved, at the time I was a director at Medicare and Medicaid. We certified the diabetes prevention program for national expansion. Now the challenge is how do we get it to people at the right place at the right time. We now know that less than 1% of pre-diabetics in the United States currently are actually getting referred to diabetes prevention programs. This is one of the things I'm really going to work on this next year. That's that end game moment. Make sure they never get diabetes in the first place. I'll close with this last story. For years, I was a counselor at a summer camp for children with cancer. And year after year, we saw there more and more kids in those pictures. And it wasn't just me. Survival rates from pediatric cancer went up from 20% in the 70s to over 80% in the 1990s. This is a guy named Chad. He was one of my teenagers who was in my tent. And him back then, and just a year ago, when he actually got married, had kids, he's now finished his residency in pediatrics at Stanford. Thousands of kids like Chad got the chance to grow up. And why did that happen? It wasn't the discovery of a new drug. No new genetic changes. Nothing. In fact, the same old regimen. What happened? What happened was this. People worked together. They banded together. They took all those little moments. They collaborated step by step, sharing data, sharing information, taking each of those little steps one by one. And over time, those small steps added up to a giant leap. So ultimately, what I'm most excited about when we think about sort of how can we make health better is to identify these moments, string them together one by one by one, and ultimately we all together will take that giant leap forward. Thank you.